It's a difficult scenario as it seems two patients need an urgent surgical intervention and potentially one of them may come to harm if they don't have the operation. So the first thing to do, as always, my priority would be patient safety. So the first priority is to stabilise both patients medically and do that to the best of your ability. If the patient was hemodynamically stable, I'd consider adjunctive investigations like CT scans, which might actually help plan the operation if the patient is stable enough. I certainly wouldn't run the patient to theatre or run one patient to theatre to the detriment of the other patient. So these patients will obviously be under separate teams, so communication would be extremely important here. The important thing to do would be to seek information, early involvement of my senior. So I'd involve my registrar, I'd involve the other team's registrar, I'd involve the theatre coordinator, the anaesthetist, as well as both consultants. Together we would assess the clinical status of both patients and the urgency of the surgery for both of them. I then want to take my initiative. I'd want to make sure that both patients, or certainly the patient that I'm looking after, is completely prepped for theatre. This would include the patient being fasted, if possible, the patient having a valid group and save, a valid clotting, make sure the patient's appropriately consented, make sure the anaesthetic review has been carried out, make sure the patients have actually been booked onto the CPOD list, make sure that any ITU beds post-operatively have been booked, and I would take that initiative to make sure that everything else that can be done is done at the appropriate time. I would then escalate, as previously mentioned, once the patients are ready to go to theatre, to allow the seniors to make the decision about who would go first. In the meantime, I want to support both patients. I want to keep them informed throughout, inform their next of kin if the patient's consented, and I want to document any information appropriately in the patient notes. If there was any harm because of the delay, because there's only one theatre available and two patients needing an operation, that would be something that would require a day ticks, especially if the patient comes to harm, to allow everybody to learn from the experience and make sure it doesn't happen again. The possible outcomes are both patients receiving appropriate timely intervention, so one of the patients who's more urgently unwell going into theatre and the other patient being consented, having valid group and save, clotting, everything else done, being appropriately worked up, including potentially adjunctive investigations like CT scans, which may actually help the surgery going ahead. So in that possible outcome is both patients having the surgery at the right time, despite one of them going first, especially if one of the surgeries is quick. The other possible outcome is one of the patients coming to harm if the surgery is delayed. And again, that's where medical management becomes very important. Early senior involvement, involving ITU for potentially organ support if necessary. The other outcome is separate theatres in the same hospital. So if another theatre is made available, perhaps by cancelling an elective operation and freeing up a theatre as well as the staff that's required to carry out the operation. So that's another possibility, finding a theatre in the same hospital. The third possible outcome is a transfer. So especially if it would require being safe to do so, the patient being stable enough, but that's the third possible outcome, transferring a patient to a hospital with the available facilities for the operation to be carried out in a timely manner. So there's various NCPOD categories. One would be immediate, which would require an operation within minutes. One would be urgent, which would require an operation within hours. One would be expedited, which would require an operation within days. And one would be elective, which would require a planned operation. There's the site team who coordinate the flow of patients from the emergency department to AMU, from the acute medical unit or acute surgical unit, from the acute medical unit or acute surgical unit to the wards, and that would be the medical bed manager or the surgical bed manager. There's also matrons involved, either in a medical ward or a surgical ward, who are involved in making decisions about what patients can come to their ward or safe to come to their ward. There would be the site manager, who would be involved in ward to ward or AMU to ward transfers. And then there would be, the general flow coordinators, all the other bed managers who are usually experienced senior nurses. There's various factors involved in ordering an elective list. One could break them down into patient factors, logistical factors, and operative factors. So patient factors would be the clinical status of the patient, how stable the patient is. Perioperative fitness, so things such as minimizing the fasting time for diabetic patients and putting them first on the list. The other would be, another patient factor would be infection risk. So patients who are MRSA positive, for example, should be operated on last. Again, if you require a deep clean of the theatres in between patients, these patients should be going last to prevent any delays. As well as things like prosthetic implants that might require a particular flow, such as a laminar flow unit. So again, that would affect when a patient would be able to go. There's logistical factors such as the availability of staff, the availability of special equipment, as well as the requirement of specific preoperative tests, such as clotting studies. And there's operative factors as well, such as the length and complexity of the operation. So again, there's one would avoid placing large complex procedures later on in the day, because that would potentially lead to fatigue, lead to delays, lead to people leaving late. And finally, the anaesthetic as well would dictate the list, the order of the list. So for example, local anaesthetic cases might go later in the list because they have a shorter recovery time than procedures that are carried out under general anaesthetic. NCPOD stands for the National Confidential Inquiry into Perioperative Deaths. I believe it's a UK charity that was born out of a report between surgery and anaesthesia called a Confidential Inquiry into Perioperative Deaths. It was established to examine the quality of care that was delivered for surgical patients. I know it's an independent organisation that receives funding from the Department of Health, and in 2002 its remit extended to cover medical patients as well. There's a network of local reporters who are clinicians who report outcomes for NCPOD. They've published over 30 publications to date with specific recommendations for improving patient care. They've contributed to many things, such as the increased availability of emergency operations or NCPOD theatres. They've again contributed to a reduction in out-of-hours operating, better trainee supervision, less inappropriate surgery, as well as better access to intensive care facilities.